Now in this part, we are going to discuss the pituitary and the thyroid glands. The pituitary gland is a gland that is found at the base of the brain. It's found in a bony depression right in the middle of the sphenoid bone. So this butterfly-shaped bone is known as a sphenoid bone. Right in the middle is a depression known as the sella turcica. Sella turcica translates literally into the Turkish saddle. And you can see it here again. That sella turcica found right above the sphenoid sinus. The sphenoid sinus is one of the paranasal sinuses that are cavities full of air, and they're lined with mucous membrane, and they drain mucus into the nasal cavity. And we'll talk about those nasal sinuses more when we get to the respiratory system. Right above the pituitary gland is the optic chiasm, which was part of the visual pathway from the eyes to the occipital lobe. And it's these anatomical relationships that give some of the symptoms of a tumor of the pituitary gland. So if a patient comes in and they have a pituitary gland growing, they're not going to come and tell you that my gland is increasing in size. One of the very first symptoms would be visual disturbances, visual abnormalities. So they start thinking that they are having eye problems, okay, because again of that relationship between the pituitary gland lying right underneath the optic chiasm. Attached to the pituitary gland is the hypothalamus. So the hypothalamus is above as well, and it's attached to the gland by a pituitary stalk or an infundibulum, and we'll see that in the next slide. The pituitary gland is made out of two lobes. An anterior lobe known as the adenohypophysis. Adeno means gland. So the anterior lobe or the anterior pituitary is an actual honest-to-goodness gland. It is made out of glandular tissue and it makes hormones. The posterior lobe, on the other hand, its nickname is the neurohypophysis, and that is not a true gland. We'll find out that it actually has the axon endings of the terminal axons from the neurons, and the cell bodies of those neurons are found in the hypothalamus. So again, your posterior lobe doesn't really secrete hormones. We'll see what it does. Again, it is known as your neurohypophysis, while the anterior lobe is a true gland with a nickname of an adenohypophysis. Now, what about the hypothalamic control of the pituitary gland? So your hypothalamus is really in control of a lot of glands. One of the most important glands that it does control is the pituitary. But it's different how the hypothalamic control of the anterior pituitary gland is totally different than its control to the posterior lobe. So the anterior lobe regulation, we'll take a look at what's going on in this part. So figure A, and here you can see the anterior and the posterior lobes found within the sella turcica. Above it is the hypothalamus, and you can see right above those as well is your optic chiasm. So again, that anatomical relationship between the optic chiasm leading to visual disturbances as soon as a person starts to get a tumor of the pituitary gland. You can see that if it'll grow upwards, since it's got bone underneath it, the easiest way for it to grow would be upwards, compressing the optic chiasm. So going back to the regulation of the anterior lobe, the hypothalamus is connected to the pituitary gland through that stalk that we called the infundibulum. And you can see blood vessels found in there. Okay, those blood vessels are known as the hypophyseal portal circulation. And a portal circulation are capillaries that connect arterioles to arterioles. So usually in the circulatory system, we talk about how it goes from artery and then smaller arterioles, then to a capillary, and then blood flows from a capillary to venules. When we talk about portal circulations, though, you'll find that it goes arterial, capillary, and then arterial again. And we only have these portal circulations in a couple of places, for example, in the liver We'll find them also in the kidney. We'll talk about them when we get to those places. One of the places that you can find a portal circulation again is in the infundibulum. So what happens is that the hypothalamus is going to release some of its tropic hormones, and those tropic hormones will reach the anterior pituitary through the hypophyseal portal circulation and be released into the anterior pituitary, leading to most of the tropic hormones are stimulatory, so they would stimulate the anterior pituitary to make its hormones. Now for the control of the posterior pituitary gland. You see here these neurons. These are hypothalamic neurons that are very special. They have the ability to make hormones. So the hormones are actually made here in these hypothalamic neurons, and then they pass along the axon down the infundibulum again and are released into the posterior lobe. Okay, so the posterior lobe really doesn't secrete these hormones. What it does is the hypothalamus makes those hormones, and these hormones are stored and released into the blood, into the circulation from the posterior lobe. So for posterior lobe regulation, you have these nerve impulses from the hypothalamus that travel through that infundibulum, and they stimulate the nerve endings in the posterior lobe to release those hormones. Now, if you look at this image, this is a very important image. I would definitely recommend printing this slide out and, going back to it as a reference. That upper bar represents the hormones coming from the hypothalamus. That middle bar or that lower bar represents the hormones that are released from the anterior pituitary. And these are the target cells of the hormones of the anterior pituitary gland. So let's take a look first off at what's going on right here. So the growth hormone that is made by the anterior pituitary gland is under the control of two hormones from the hypothalamus, either the growth hormone releasing hormone or somatostatin. Somatostatin is also known as the growth hormone inhibiting hormone. So GHRH would stimulate the release of growth hormone from the anterior pituitary, while somatostatin would inhibit the release of growth hormone from the anterior pituitary gland. Now, growth hormone, if it is stimulated and if it is secreted, has three target cells. First target in the bone, second would be your muscle, and third is the adipose tissue. And it will obviously stimulate the growth of all three of those target cells. So it stimulates the growth of bone, it stimulates the growth of muscle tissue, and it stimulates the growth of the adipose tissue. Now, another hormone that is released by or secreted by the anterior pituitary is prolactin. Prolactin is under the control of two hormones coming out of the hypothalamus. That is prolactin releasing factor and prolactin inhibiting hormone. Again, either stimulating or inhibiting the secretion of prolactin. Prolactin reaches its target cell in the mammary gland, and it stimulates the production of milk during lactation. It also prepares the mammary glands during pregnancy in order to prepare for breastfeeding after delivery. Now, a third hormone that is released from the anterior pituitary is known as the TSH, or thyroid stimulating hormone, and it's under the control of TRH, or thyrotropin releasing hormone from the hypothalamus. This would stimulate the release of TSH from the anterior pituitary. TSH goes through the circulation to stimulate the thyroid gland to make its hormones. Now, CRH, or corticotropin releasing hormone, released from the hypothalamus, would stimulate the anterior pituitary to secrete ACTH, or adrenocorticotropic hormone, and its target cell is the adrenal cortex, stimulating the adrenal cortex to secrete its hormones. Gonadotropin-releasing hormone is the last of the hypothalamic hormones that we're going to be talking about, and that stimulates the anterior pituitary to make two different hormones, either luteinizing hormone or FSH, also known as follicle-stimulating hormone. The targets of these hormones are the ovaries and the testes. So in males, there is luteinizing hormone and FSH as well. Sometimes they have different names, but they're the same hormones. And FSH stimulates the production either of the eggs or the sperms, while LH is going to stimulate the ovulatory process, so stimulate ovulation and the release of progesterone from the ovaries, while LH will stimulate the testes to secrete androgens. Now here you can see the hypothalamic control of the peripheral endocrine glands, meaning how is it that this hypothalamus up here, how does it control these peripheral glands? It is obviously mediated through its action on the anterior pituitary. And that's what it's talking about. So you can see here the hypothalamus will release a hormone, the first one in the series, to stimulate the anterior pituitary. The anterior pituitary releases a second hormone, and it's that second hormone that is going to stimulate your peripheral endocrine gland. So I've used the thyroid gland as an example. So TRH is released from the hypothalamus, will stimulate the anterior pituitary to make TSH. TSH through the bloodstream will reach the thyroid gland to make thyroxine. Now that all of these levels are up, by negative feedback, you have thyroxine would inhibit the anterior pituitary and the hypothalamus and stop them from making more hormone. Well, I can see here a shorter loop where the TSH released from the anterior pituitary by negative feedback would inhibit this higher hypothalamus from making too much TRH. So all of these, again, are negative feedback control. Now, your anterior pituitary hormones, we talked about a lot of these different hormones. The anterior pituitary has different kinds of cells, and that's why we have all 5 or 6 of these hormones that are being made. And they are, and I used this mnemonic to kind of remember what it is. So a flat pig, F stands for FSH, L is LH, A stands for ACTH, T stands for TSH, P is for prolactin, I is not from the anterior pituitary, so you could ignore that, and then G is the growth hormone. Okay, so you want to be familiar with the different kinds. You should be able to figure out when you get a hormone, identify which gland secretes it. Now, these, again, are the actions of these hormones. So we will talk, kind of go in the order of that mnemonic. So the follicle-stimulating hormone is going to cause the growth and development of ovaries in females, and it will stimulate the production of sperms in males. So this process is known as oogenesis, or the generation or the creation of eggs, and this is known as spermatogenesis, or the creation of sperms. Now, luteinizing hormone, or LH, that is going to lead to ovulation in females, while in males it will lead to, and also the release of progesterone from the ovaries, while in males it will stimulate the testes to release androgens. So you see here that it produces sex hormones in both genders. Now, ACTH, that stimulates the release of cortisol and other hormones from the adrenal cortex. TSH, or thyroid stimulating hormone, that stimulates the secretion of T3 and T4, which are thyroxine hormones from the thyroid gland. Prolactin, that promotes milk production in females, and the function of prolactin in males is really not known today, till this date. Growth hormone, that stimulates, like I said, the growth of your target areas, and those are mainly the bones, skeletal muscles, and adipose tissue. So it increases protein synthesis, it decreases the rate of carb usage, and it increases the rate of fat usage. So we're going to kind of, utilize that fat in order to stimulate or to fuel the growing process. Now, little clinical application related to the growth hormone. So what if a person has too much or not enough growth hormone? So not enough would be known as a hypopituitary dwarfism. So dwarfism means that stunted growth, stunted physical growth, okay, nothing wrong with the mental development. And so short stature, if it's due to the lack of growth hormone during childhood, it leads to proportionate dwarfism, where the different parts of the body keep their proportions, normal proportions in relationship to each other, but they are just smaller or shorter than normal. Okay, so it's caused by deficiency of growth hormone during childhood. Now, the increase of growth hormone can either lead to gigantism or acromegaly, and that depends on when the oversecretion of growth hormone happened. So if oversecretion of growth hormone occurred during childhood, before the growth plates or the epiphyseal plates in the long bones have totally ossified, that means that these bones still have the ability to get taller. Okay, this is usually caused by pituitary tumor. And you can see here, this individual right here has gigantism compared to a normal adult male. So again, gigantism would be due to the oversecretion of growth hormone during childhood before the ossification of the epiphyseal plates. Now, acromegaly would be the oversecretion of growth hormone during adulthood after the ossification of these epiphyseal plates. Now, since these growth plates are now all ossified, the bones cannot grow in length, but they are going to grow in width. Okay, so you find that the bones start to thicken. And you can see here how the facial features have totally changed in this young lady. You can see now there are coarser features. You can see how the hands have changed as well. So there's no increase in height, but the bones start to thicken. There's also enlargement of the tongue, nose, hands, feet, jaw, and the heart and the thyroid gland, because there is oversecretion of growth hormone leading to the growth of all of the tissues. Now, what are the hormones of the posterior pituitary? Remember that these are not secreted by the posterior pituitary. Okay, it's a trap, folks. The hypothalamus secretes these hormones and then stores them in the posterior pituitary, and that's where they're going to be released from. The two hormones are ADH, or antidiuretic hormone. The old name was vasopressin, and that hormone is released when there is a dramatic decrease in blood pressure, so severe hypotension. For example, if somebody has severe bleeding or severe dehydration. It's going to lead to the decrease in urine production. So the hormone is literally telling you what it does. I'm an antidiuretic. I am not going to produce urine. So there's a decrease in the urine production, okay, in order to keep that water and preserve it in the body. And the other thing it does, you can kind of guess it from the old name, which is vasopressin. It is going to press the blood vessels, so vasoconstriction of the blood vessels. And that is in order, again, to increase the blood pressure. So again, it's secreted, or its secretion is stimulated by severe hypotension. And in order to keep the blood pressure to make it go back up to normal, it would decrease the amount of water being lost in urine. So keep that water in the body and constrict the blood vessels to increase your blood pressure back up. Now, the second hormone is oxytocin, and that causes contractions of the uterine wall during childbirth. It also contracts the smooth muscles in the mammary glands to eject the milk during lactation. It's also the hormone of emotional bonding between mom and baby. And again, the function of it in males is not known yet. It is thought, though, that it is also responsible for that emotional bonding between dad and baby. Now off to the thyroid gland. The thyroid gland is a gland that is found in the neck. It looks like a butterfly. It has these two lobes, and it's connected in the middle through an isthmus. This is all thyroid tissue. It's found right underneath the larynx, and it's kind of hugging the upper part of the trachea or the windpipe. And the thyroid gland produces 3 hormones. 2 of them are thyroxine. So we've got T3 and T4. T3 stands for triiodothyronine, and T4 stands for tetroiodothyronine. The thyroid gland has the ability to trap iodine from blood. It's going to take those iodide ions and use it in order to make T3 and T4. So T3 stands for, again, triiodothyronine, which means that it uses 3 iodide ions. T4, though, used 4 ions. Okay, the third hormone that the thyroid gland makes is calcitonin. The thyroid gland has 2 different kinds of cells, and we'll take a look at them. Oh, they're right here. Okay, so it has what are known as the follicular cells. This right here, that yellow part, is a follicle, and this is where the thyroxine is going to be stored. So the follicular cells make thyroxine, and then it stores it in that colloid attached to a protein, and that is known as thyroglobulin. So you have your thyro portion, which is thyroxine, and the globulin is the protein. So that colloid, again, is thyroxine stored as thyroglobulin. Again, thyroxine is made by these follicular cells. In between follicular cells, we have these extrafollicular cells, okay, or also known as C cells, and those produce calcitonin. Here again is a microscopic picture of the thyroid gland where you can see follicles surrounded by the follicular cells that are going to make, these are the cells that trap the iodide from the blood, and they make T3 and T4. And then T3 and T4 are going to be stored as colloid attached to a protein. We call that thyroglobulin. Well, we have these extrafollicular or C cells that are found outside of the follicle, and those again are going to secrete calcitonin. So what are the functions of these hormones? Well, we'll talk about T3 and T4 together, okay, because they technically have the same mechanism of action or same action. The only difference is that T3 is much more potent. You can see here that it's 5 times stronger than T4 is. So what stimulates the thyroid gland to produce T3 and T4? Well, that is TSH coming from the anterior pituitary gland. So that is your source of control of thyroxine. The action that they produce, well, first of all, it is the hormone of metabolism. It is responsible for what is known as the BMR, or the basal metabolic rate of the body. And that is why if anybody has low metabolism or very high metabolism, the first thing they would do would be to check their thyroid hormones. Because again, T3 and T4, or thyroxine, is the hormone of metabolism. It also increases the rate of protein synthesis. And a couple of years ago, not a couple, but like 10 or 15 years ago, thyroxine was being sold over the counter as a weight loss product. And it was obviously taken away right away because there are lots of side effects to this. But you can actually think about it as the perfect weight loss thing to do. It increases protein synthesis. Okay, so you're making more muscle. It increases metabolism, so you are definitely burning and losing weight. It increases the breakdown of fat, which is known as lipolysis. Okay, but it also obviously has lots of side effects, so it can lead to tachycardia, high blood pressure, and all other different side effects. T3 and T4 are also important for normal maturation of the nervous system. So in utero, if the fetus isn't making enough thyroxine, they will develop a condition known as neonatal hypothyroidism or cretinism. And that is because, again, thyroxine hormone is extremely important for the maturation of the nervous system, the production of dendrites, and the production of myelin sheath. Now, for calcitonin, okay, the source of control of calcitonin is the blood calcium levels. When the blood calcium levels go up, okay, so in the case of hypercalcemia, that is going to stimulate the thyroid gland to produce calcitonin. Calcitonin lowers the blood calcium and phosphate ion concentrations. And it does that through 3 different ways. Okay, it will inhibit the release of calcium from the bones. It will increase the rate of which calcium and phosphate ions are deposited onto bones. So in this case, it will stimulate your osteoblasts and inhibit your osteoclasts, and it increases the excretion of calcium by the kidneys. Okay, all of these attempts will take the calcium from the blood and deposit it onto the bones in the hopes of bringing that calcium levels back down to normal. It will also push the calcium to be excreted by the kidneys in urine. Now, what are the disorders of the thyroid gland? And I have a goiter as, the question mark here, because goiter just tells you the size of the gland. So a goiter is an enlarged thyroid gland. It does not tell you anything about the function, though. So the conditions here, so in any of these conditions, that person could have a goiter, and again, the gland could be huge, and I'll show you a couple of pictures, but the function is actually the total opposite. We'll talk first about hyperthyroidism. So these individuals are producing too much thyroxine. Remember, thyroxine is the hormone of metabolism or metabolic rate. So patients or individuals that have hyperthyroidism will have a very high metabolic rate. They're going to have tachycardia, digestive disturbances. They will definitely have weight loss. They are going to have intolerance to heat, restlessness, hyperreflexia. So if you check the reflexes, they are exaggerated. They have protruding eyes and a goiter and an enlarged gland. Okay, we'll show you the pictures in the next slide. Graves' disease is a patient that has hyperthyroidism due to an autoimmune cause. So these individuals, and it's usually females, so autoimmune diseases tend to be more common in females. We have these autoantibodies that bind to the TSH receptor found on the thyroid gland, and that is going to mimic the action of TSH, and therefore overstimulating the thyroid gland to make lots and lots of thyroxine. So they have hyperthyroidism, and they have exophthalmia, which means if you look at them, they look like they're staring at you. So there's the protrusion of the eyes, and goiter as well. So we'll take a look at the picture and then we'll come back to this slide. So you can see here in this Graves' disease, hyperthyroidism, you can see the enlarged thyroid gland in the neck. And if you look at the eyes, they look like they're staring at you. So there will be sclera all around the eye. And that again is known as exophthalmia or exothalamus. Now in hypothyroidism, so again, they could have a goiter, meaning the gland could be enlarged, but function-wise, there is hypofunction. We'll talk about the autoimmune cause, which is the most common cause of hypothyroidism, known as Hashimoto's thyroiditis. Again, it's an autoimmune disease where we've got autoantibodies that destroy the thyroid cells. Another cause of hypothyroidism is simple goiter, and that is also known as endemic goiter, meaning that it's more common in areas that are far away from the sea. So remember that the thyroid gland needs iodine in order to make thyroxine. Iodine is mostly found in sea products. So for people who don't live by the sea, you would find whole communities that would have this simple goiter. That's why it was called endemic goiter, because you can find it kind of endemic and in certain parts of the world. This is no longer an issue though, because now if you look at your salt, it will say iodinized salts. So small amounts of iodine have been added to table salt, and this is no longer an issue, public health issue. But in simple goiter, okay, these glands would not couldn't find iodine, so they would actually not be able to make thyroxine. That is going to be picked up by the anterior pituitary. It will make more TSH. TSH is going to try to stimulate and push the thyroxine gland to make hormones, and that is why the gland is enlarged. So if you see here, this is a case of a simple endemic goiter, and you can see how big that gland is. But again, it's just big in size, but function-wise, it's actually hypofunctioning. Okay, these individuals would have low metabolic rates. They would actually have intolerance to cold weathers. They would have weight gain, hyporeflexia, so the reflexes would be lower than normal. They could have menstrual abnormalities. So those are your thyroid disorders. You can also see the case of infantile hypothyroidism that we talked about when we mentioned that, again, thyroxine is extremely important for the normal development of the nervous system. This is now actually something that is screened as soon as the babies are delivered. And if it is found that the baby has infantile hypothyroidism, it is reversible if they are given thyroxine hormone right away. Now off to the parathyroid glands, and those are the glands that are found behind the thyroid gland. So this is the posterior side of the thyroid gland. You can see you've got two on each side. They're kind of like little peas. They are found on the posterior surface of the thyroid gland. We have 4 of them, and they secrete one hormone known as parathyroid hormone or parathormone, or PTH for short. PTH regulates calcium and phosphate concentrations in blood, kind of like calcitonin, but it does the exact opposite of calcitonin. Now, the stimulus to make parathyroid hormone would be decreased blood calcium. So hypocalcemia will stimulate the parathyroid glands to make PTH. PTH will go down the bloodstream to its target cells, and you can see the target cells would be the bone. So PTH would go to the bone to stimulate the osteoclasts, and that would increase bone resorption, releasing calcium into the bloodstream. PTH goes to the kidneys and conserves calcium, so prevents calcium from being excreted in urine. And it also activates vitamin D, and that's an extremely important function for PTH, where it activates vitamin D in the kidney, and it's that active vitamin D that allows or makes the intestines able to absorb calcium. Now, all of that calcium that was either prevented from being lost in the urine or absorbed from the diet will bring back those calcium levels back up to normal. And by negative feedback, that would inhibit the parathyroid glands from making more PTH. Now you can see that vitamin D, we talked about how PTH has to activate vitamin D in the kidney. So why is it that vitamin D needs that activation? Well, we take vitamin D in 2 forms, either from food or we make vitamin D by using the ultraviolet light in the skin. Both forms, whether we eat it or whether it's made in the skin, both of them are inactive. And that has to be activated in 2 steps. The first step is in the liver, and the second step is in the kidney. And it's that step, again, that is stimulated by PTH. So in the absence of PTH, we will not be able to activate vitamin D, and these individuals will have vitamin D deficiency, and they will also have calcium deficiencies. Now for the disorders of the parathyroid gland, either hyperparathyroidism, mostly due to a tumor, and in order to treat that, you can go ahead and remove those tumors. Hyperparathyroidism, these patients would have hypercalcemia, and they would come in with symptoms of fatigue and muscle weakness, depression, weight loss, bone weakening, because all of that calcium is coming actually from the bone. Remember, increased PTH is going to overstimulate these osteoclasts, and so eventually there's a lot of bone loss, and that can lead to osteoporosis. So the treatment would be to remove the tumor and to make sure that you're also treating any bone deformities. Hypoparathyroidism usually is due to the inadvertent surgical removal. So if a patient gets a thyroidectomy, because these parathyroids are right on the posterior surface, sometimes they're even embedded within the thyroid tissue, these parathyroid glands sometimes are removed by mistake. Or if a patient has thyroid cancer, then they are removed to make sure, just in case that cancer has invaded the parathyroid tissue. Okay, so that is the cause of hypoparathyroidism. The symptoms, the patients would have muscle cramps and seizures. Okay, and the decrease in the para-PTH secretion reduces the osteoclast activity, and that's why these patients have hypocalcemia. And it's the hypocalcemia that manifests itself in muscle cramps and seizures. In order to treat them, you want to give them calcium salt injections and massive doses of vitamin D. Remember, they are lacking in PTH, so we can no longer activate vitamin D, so you would have to give it to them. And that ends this portion of the lecture.